Hello there, everyone. This is Kamran Bhopal again, and this is a station where we go over some important questions of the bladder cancer scenario or visible hematuria scenario. We've already discussed the history, so you can go back and look at the history station for visible hematuria and how we risk stratify different type of urological cancers. Now we're specifically going to talk about some bladder cancer questions. After the initial history, what investigations would you perform? So simple questions, urine dip and culture, urine cytology can be considered, routine bloods, full blood count using CRP, and a PSA blood test. Then radiologically, you can get an ultrasound of the urinary tract for non-visible hematuria or a CT urogram with an excretory phase in visible hematuria. And lastly, we need to organize a flexible cystoscopy. So these are the things that are the important investigations. If you want to get some brownie points, you can say these are not regularly used, but other urine molecular markers such as the NMP22 and Eurovision can be used and improve diagnostic sensitivity, but are not in routine practice in the NHS. So this is a question which they usually ask. So what investigations? Then there will be a question about how will you consent for a TURBT. I'm not going to go into the consent because you can get it from the BAUS website, and you can just make your own list about how you're going to say all of the risks. The important things, the way I used to consent, and I might just say this in the clinical skills station, but I'll say it now as well, was consent is a multi-step process, and I would start consenting the patient in outpatient and then on the day. I will use a consent form 1 if the patient has got full capacity, and then confirm the patient details and my consultant's name, tell them the name of the procedure, then intended benefits, explain using visual aids and BAUS leaflets, risks involved, extra procedures that may be needed, and then sign and date and ask the patient to do the same and ask if there's any questions. Now, this is a basic guideline for every consent that you do. And the important things is to remember those risk factors, because risk factors are different for everyone. The rest of it is all same. In surgeries where you have to mark, obviously in bladder cancer you don't have to mark for TURBT or anything, but in surgeries where you have to mark, I usually say the marking at the time of the procedure. So I would tell them the name of the procedure, blah blah blah, and explain the procedure using BAUS information leaflets and visual aids, and also mark the patient at the same time. It's important to say that just so that they know how you're thinking, because I do that regularly in clinical practice. We might as well say it in the interview, and this shows that you consent patients regularly. So yeah, so a lot of people got confused. I had to read through multiple sources for this, and you have to find out a precise answer for the risk stratification of superficial bladder cancer, so non-muscle invasive bladder cancer. And the way you stratify it according to NICE as well as EAU guidelines, I made a very brief answer. So number 1, low risk is single less than 3 centimeter G1 or G2 PTA bladder cancer. Then you've got intermediate risk, which is multifocal or single greater than 3 centimeter lesion, G1 or G2 PTA. And then high risk is any G3, any PT1, or any CIS. So remember this, this is exactly what you have to say in an interview. Just say it in one line the way I've said it. Low risk, single less than 3 centimeter tumor, G1 or G2 PTA is low risk. Intermediate risk is multifocal or single tumor greater than 3 centimeter, G1 or G2 PTA. And high risk is any G3, any PT1, and CIS. So all of them are high risk group. So this is an important one. Something to add, I'll just mention it because there's a couple of things. When do we offer a redo TURBT? Number 1, if there's incomplete resection and we want to completely resect it. Number 2, if there is G3 or T1 disease, usually that is, we're talking about high grade risk stratification of bladder cancer, so you need a re-resection in 6 weeks. And number 3, if there was inadequate muscle specimen, so there's no muscle in the specimen, so you cannot say whether this is a muscle invasive bladder cancer or a non-muscle invasive bladder cancer. That is the third indication, that if there was no muscle in the specimen, we have to redo it to just confirm that it is not involving the muscle, because the management then changes if the muscle is involved. Then staging. Okay, so you should be aware of what is the staging of bladder cancer. I can quickly go over all of it. So TIS is carcinoma in situ. TA is superficial bladder cancer on the submucosa. T1 is when it involves the subepithelial connective tissue. T2 is when it invades the detrusor muscle. T2A is when it involves half of the detrusor muscle. T2B is when it has gone through the detrusor muscle all the way. T3 is when it has gone into the perivesical fat. Now T3A is when it is microscopic invasion, whereas T3B is when it is visually or macroscopically invaded the perivesical fat. T4 is when it has gone beyond the perivesical fat in the surrounding structures, and that is also divided into 4A and 4B. So 4A is usually prostate, seminal vesicles and vagina, whereas 4B is the pelvic and abdominal side walls, which is the sort of significant localized spread. So this is your staging of bladder cancer. And then, yeah, I think that's about it. Those are the important questions. Sometimes, you get confused on the risk stratification. So I thought I'd just put it out there according to the EAU and NICE guidelines. This is how you risk stratify non-muscle invasive bladder cancer. And staging you can understand from any book as well, but I thought I'd mention it. I hope you've learned from it, and we will keep on doing further videos on questions with regards to this. I wish you all the best. Take care. Bye-bye.